I just really liked that I could treat someone medically on the outside, but help them to feel better about themselves on the inside too.
Welcome to That's Derm Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Welcome to That's Derm Good. Today, my guest is Dr. Victoria Farley. Dr. Farley is a board-certified dermatologist with Vivita Dermatology in Las Vegas. Thank you, Dr. Farley, for joining me.
Of course. Thank you so much for having me.
Yes. So I met you at the I Reclaim Summit.
Yes.
And it was so exciting to meet you. You just brought such a fun energy to the stage when you were presenting. And I was like, she seems so fun. I need to have her on the podcast and chat with you.
Awesome. Well, I'm so happy to be here. Thank you so much for having me. That was actually a really fun summit. So
it was. So it was my first time going, and, it was my first time being at a conference with patients. And I thought that was really cool just to be able to hear from patients and, talk about access, because that's, my jam. But, it was just really cool just to be able to meet so many people and so many advocates. So it was such an amazing experience.
I agree. It was my first time going to a patient-centered conference as well. Of course, being a physician, we do a lot of continuing education conferences, throughout the year, but they've all been very clinician focused as far as, just, getting your continuing education for yourself and for your patients. But it was really neat seeing it from the patient standpoint and what the patients want to hear and what their questions were. And also to see them interact with each other and just the forum that it overall provided for the patients to feel like they were in an open space that they could just talk and ask and not feel silly or stupid, or, like they could just ask and their questions could be answered. So I thought it was great. And unfortunately, in these times of misinformation, I thought it was a great place for them to go and actually get legit, good, solid information on a multitude of topics that really covered their well-being from multiple angles.
Yeah, absolutely. I agree. And I think sometimes when patients sometimes get together, I feel like you can almost kind of have like almost a negative, like, oh, what's the office not doing? Or how come this information is not getting out? But I really feel like it was genuinely a place to learn and to understand on both sides. I was there to learn and to understand, but also to provide some education and support around access, which is a hot topic. It's so difficult, and it kind of opened my eyes too. I'm like, wow, I didn't realize that so many people are still struggling with access, and that, going to their doctor's office, they may not get that care that they need, or maybe they're not going to the right doctor's office. And I didn't realize how difficult that really was.
Unfortunately, it is. And you're right. It sometimes can be hard depending on, the type of access or funding they have, as far as, are they able to just make an appointment with a specialist, or, do they need to see a primary first? And then what can be hard is, especially for a condition like hidradenitis suppurativa, even within dermatology, there's some of us that this is our jam and our passion for treating it. And there's some people that don't see it as much. So sometimes even you get to a specialist and it may not be the right specialist, so right. There's definitely a tricky one. And then once you get there, getting the medications is a whole nother access issue. So yeah, it really was a good summit. I'm really glad they put it on and they have it. So
yeah. So what was your talk about?
Yeah, my talk was on surgical options for hidradenitis suppurativa.
Okay. And so you do that in your office yourself, right? You do surgical procedures.
Yes. And so as far as surgical options, there were different aspects of it. So there's some when they're smaller procedures that we can do in the dermatology office because they're done under local anesthesia. And so for those patients that really need that procedure in the office, we can do it. For some of the bigger procedures, unfortunately, for patients with more significant disease or a bigger burden of disease, sometimes the surgical treatment they need is not the type that can be done in the office, but is the type that they need to be in the OR. So then those patients often need to see either a plastic surgeon or a colorectal surgeon. So it was kind of going over, what was the route that you need to take depending on the type of treatment you have. Are you a good patient for one or the other, and how do you know? And
Right.
kind of those options. So
Yeah. So do you find most patients even know that surgery is an option for
yes.
HS?
Well, it's hard. So, unfortunately, I mean, it's definitely getting out there, but some patients, unfortunately, are still just learning about the disease themselves. Then
Mm.
learning about your treatment options from there is a whole different story. What's tricky is a lot of the patients that actually need surgical treatment often need medical treatment together with it to really get the optimal outcomes. What's another challenge with not even making sure that the patients are aware of all their options is also making sure that the surgeons are aware of the options, because
Mm.
I certainly would never expect a surgeon to go through in detail or to know all the medical options. But to me, what a surgeon should optimally do is recognize that, hey, if this patient's condition is this significant that they're needing me to surgically excise a given area of skin because of their involvement with their HS, they are going to be needing medical treatment afterwards, not only to keep that area clear, but to keep any other areas of involvement, to keep that inflammation down as much as possible. And actually, a lot of times, even pre surgery, which ideally they would see us in conjunction with the surgeon, we can often be helpful from the medical management to try and make that surgical area as small as possible and get all that inflammation and everything down as much as possible, so then it heals better and does that much better for the future.
Hmm. So, with so many of the biologics that are out now for HS, how does that play a role in that? Would that be more of a maintenance type
Um,
decision or?
Yeah, so they are often maintenance treatments, but again, where they can be helpful is, unfortunately, I've had some patients when I first meet them that they have multiple areas of involvement. And so,
Mhm.
for listeners that don't know exactly all the areas that hidradenitis can affect, it tends to affect anywhere skin comes together. So, underneath the underarms is a common area, between or underneath the breast, the groin or the genitalia, or even like the gluteal cleft buttocks. For some patients, it can even be on their back or the back of their neck. And I've seen patients that have multiple, sadly, if not all those areas involved at the same time. So if you can
Mhm.
imagine having to have surgical treatment in that many areas, that's
Right.
a lot of surgery. So
Mhm.
if you can potentially bring it down to maybe I only got one or two spots now that are really stubborn with medical management, whether it's biologics, other oral therapies, or even all of those together and need surgery, well, now that's a much more manageable task. And again, it also helps it for as it's healing in the future to not only remain clear, but hopefully you're not getting involvement elsewhere.
Mhm. Yeah. So tell me, how did you become such an expert in this? Why did you get into derm in the first place?
Yeah,
And
with derm, it sounds a little cliche, but growing up, one of my really good friends in middle school and high school sadly had really significant cystic nodular acne. And my uncle has vitiligo, which is a condition where you lose the pigment in your skin color. And his non affected skin was fairly brown like mine. So it was very obvious what patches were involved and which ones weren't. And for vitiligo, a lot of times it will affect people's very visible areas. So, like their face, like around their eyes, around their mouth, hands, elbows, knees. So for me growing up, I saw with both of these people who had these conditions of no fault of their own. Sadly, just human nature. Some people, when they see them, are like, "Oh, nice to meet you." Like sadly, they if they could back up their seats anymore, they would have. And these are
Mhm.
conditions that are not contagious; they're not infectious. But unfortunately, with dermatology in general, because the conditions are visible, these patients get affected not only physically with the conditions they have, but it also affects them on the inside. I mean, no one likes to feel like they're being judged. And so I just really liked that I could treat someone medically on the outside, but help them to feel better about themselves on the inside too.
Yeah, I love that. I mean, I feel like a lot of times it just comes from that personal experience and the desire to want to help others and your family and friends, especially. So that's amazing. And you're double board certified in internal medicine and dermatology.
I did my residencies in both. To be completely accurate, my internal medicine certification has lapsed, but my dermatology certification is definitely still active. I did do two residencies. You are correct. And at one point
Okay.
in time, I was double board certified. My testing for the internal medicine has lapsed.
So that training that you have though, how do those fields complement each other in your work? How does that help you?
Yeah, no. So actually, they've come together really well for me. So, what's been really awesome for that is I like doing medical dermatology, and a lot of times, even what's called complex medical dermatology, or I'll work a lot of with oncologists as far as like patients that are having rashes from, for instance, like chemotherapy or radiation, things like that. And what can we do to help to treat those patients so they can get the treatment they need? Because, of course, if you're receiving a chemotherapy that is killing off your cancer, but it's causing a rash that's making you be very itchy or it's burning or something. Obviously, I want the patient to be able to finish their chemotherapy so that they can live a long, happy life and not have an active cancer. But sometimes, depending on the rash they have, that may be limiting their ability to complete that medication treatment. So hopefully I'm able to allow them to get through what they need. So then not only do they become cancer free or in remission, but then also they're able to tolerate it as well as they can if they need that treatment. So
Yeah.
and just being doing those rotations and being familiar with those medications, because a lot of medications have interactions, and just being familiar with them and the type of treatment courses patients are going to need for different conditions, it just kind of has all aligned together. So
Yeah, because internal medicine just really focuses on the body as a whole, right?
yeah.
Yeah.
So we did rotations in nephrology, which covers your kidney, and rheumatology, which is a lot of different autoimmune diseases, oncology, which is cancer. So it like you said, all the different parts of the body, but internal medicine as a whole, yes, covers the whole body. So
Wow. Yeah,
yeah.
that's cool. I
Thanks.
love that.
Thank
It's
you.
so, it makes sense because but I think a lot of times you almost kind of compartmentalize like medical space. You go to your primary care physician and you think they should know everything about everything. And then until it's a specific thing, and you're like, nope, you got to go see a dermatologist for this. So,
You're 100% correct.
yeah.
Yeah. And it's so much to keep up with, it is hard to keep up with all of it. So that is part of why, unfortunately, sometimes it does get a little compartmentalized, because to really be an expert in your field, it's hard if your field is too big. So, trying to
Mhm.
keep it a little bit more manageable allows you to stay up with everything as best as you can.
Yeah, that makes sense. So you also do a lot of clinical trials in your practice.
Correct.
So yeah, tell me a little bit about that. How these clinical trials really help patients, and what does that look like for patients to get enrolled? I used to work in a little bit of clinical trials at an office that did clinical trials. I thought it was the most amazing thing, but not everybody understands the need or the value behind doing that in the office.
Yeah, no, clinical trials has really been great. I've loved what it's been able to offer my patients as far as getting brand new treatments. And then I also love what it's allowed me to do as far as I'm able to get really comfortable with medications before they even hit the market. So when
Mhm.
patients are asking things about, what kind of side effects do I need to worry about, or blood work, I can really talk to patients not only from a matter of saying like, oh yeah, well, I read this paper that says X, Y, or Z, but I can also speak to it from a sense of, no, when I was part of these trials, these were what my patients experienced. And this is when we were checking blood work or monitoring different things way more often than we do in real life. This is
Mhm.
actually what we saw. So it also gives just more credence and confidence to it as the clinician, because you've worked with these medications for so long already before they even make it to the market. So from a patient standpoint, what they really offer them is, unfortunately, even though HS is definitely getting much more recognition and more attention and treatment to it, we still really have a long ways to go as far as hitting that silver bullet and getting the right
Right.
treatment that works for everybody. So although some of the treatments we have definitely made huge headways for a big chunk of our patients, unfortunately, there is also a big chunk of our patients that have still not reached that mark of where they want to be in their disease. So for those patients, or unfortunately, patients that don't have access for one reason or another, whether it's financial, insurance, etc. Clinical trials offer them a way to get these medications and to get their treatment under control, either if they've already exhausted all the options that are available to them, or again, if they're having access issues that they can't get potentially some of the options are available. Well, now they can get cutting edge treatment and they don't have to worry about the financial access issue.
Yeah, absolutely. Typically, are they always paid for patients?
Yes, I've never had one that wasn't paid. But yeah, I mean, all of course, the actual visits, the blood work, any, if you need chest x-rays, any kind of testing or monitoring you need is all covered by the sponsor. Any visits you have are free. And then a lot of the patients will often get some type of reimbursement either for their time of the visit plus or minus even travel expenses, because
Mm.
unfortunately there's not a trial usually in every big city across the country, so it may only be in a certain number of states, so then some people may need to travel to get to a clinical site, and so a lot of the sponsors will offer travel expenses as well.
Yeah. So what does that look like for like time wise for a patient, when they're starting a clinical trial? How long are they in that trial before or when that ends and then before the product actually launches?
That's a great question. So within the trials themselves, so there's different phases. Like if someone is reading or looking up anything on clinical trials, they'll have like phase 1, phase 2, phase 3, phase 4. And essentially phase 1 is a lot of times actually just with healthy volunteers, and they're just seeing, is the medication safe or not. Phase 2 and 3 are kind of expanding out the number of patients that are involved, and they're trying to see like which dose is going to work the best for patients. And of course, during that whole time with lab monitoring and other monitoring, you're also looking for safety and potentially any side effects. And then
Hmm.
a lot of times phase 4 trials are done once the medication has already reached the market, but maybe they're looking at certain things, whether it's in the diversity of the populations or things like that they're kind of doing post market. So a lot of times, the thing is though, with some of these conditions, so for, hidradenitis suppurativa, alopecia areata, vitiligo, a lot of those conditions, it can often take a while, sometimes depending on the severity of the disease, for the medication to fully kick in to see, is the patient receiving a response or not. So some of these now, they'll actually be so long that sometimes it actually has gotten approved before the extensions have ended. So it kind of varies. Like right now, I was actually just looking at with my research coordinator that one of our HS trials, ultimately till the very, very end, like the safety follow up visit, once they've been off the medicine for a little bit, it actually ends up being 4 years, which is, again, especially for patients that cannot access their medications, that's pretty awesome that they get 4 years of free drug.
Hmm.
But yeah, it just kind of varies. Some of the phase 2 trials might only be 16 or 24 weeks, so
Mm.
it just kind of depends on what the specific condition is that you're treating and which phase it's in to determine how long the trial will be overall.
So what happens if it's an amazing drug, it goes to market, is all the clinical trial is over, and that patient wants to continue that medication?
That
Like,
is yes, that's a great question. So the good news is a lot of the sponsors will try to work with the patient to help them receive their medication once the trial has ended.
okay. Yeah, because it's like, it's really it's starting a medication and then it's like, okay, now the trial's over. See you
Yeah.
later.
And I will say the good thing is that if it is an awesome medication and it
Hmm.
makes it to fruition that it does become approved, then one big thing I always emphasize to patients whenever, not only before they start the trial, but even once they're actually in it, I always tell them, there is no such thing as research jail. Like you are the king or queen of as far as your role in this. So if at any time either you're not feeling comfortable with the trial, whatever, you can take yourself out. But
Mm.
same thing too, the sponsors also know all that and they want the patients to know that. So, once a medication has gotten approved that patients are wanting to go more that route rather than continue the trial, they'll help them with that process as well.
Yeah. So, one thing that I always found was interesting about clinical trials is when you're in this trial, every little thing that happens, if you got a cough or you get a sneeze or, whatever it is, you've got to record all of that.
Correct. And so that actually is a great point. I am so glad you brought this up because I think this is actually a really important thing to get across to people is, yeah, so whenever you're in a trial, my patients always laugh at me because I'm like, all right, here's where I'm about to sound like the Pepto-Bismol commercial. Have you had any nausea, vomiting, that little commercial, diarrhea, indigestion, fevers, chest pain, shortness of breath, headaches, numbness, tingling, so we ask all that. And if the patient says yes, all right, ding, we write it up. When you're filling out that adverse event report, you do fill out on there, like if you think it's related to the medication or not. But
Mhm.
on the flip side, so let's say everyone does really well, the safety looks great, and so the medication gets approved. Well, we've all heard the commercials on TV, side effects
Mhm.
include. Okay, well, that's where they come from. Are
Right.
people like me that are asking, and oh, this person said a headache, so side effects include headache. It's like, well,
Right.
she had a headache also because she said she went hiking for 3 hours and didn't drink any water. But that doesn't matter. It's
Mhm.
still going to get counted as a
And that
headache,
and that kind of,
So
I don't know, it's kind of sad because there could be some really amazing drugs and something could happen in that clinical trial, and just take like, some drugs that are for psoriasis that have black box warning,
hmm
particularly one that I know of that is an amazing drug, because I remember those clinical
hmm
trials and the patients that were in it that completely cleared, and it was just awesome. But nobody wants to write it because of a black box warning. And the black box warning, I mean, I just don't feel like it really speaks to the drug itself. So how, like,
And
why is that?
that's a great question also, and it's hard because the black box warnings are put up by the FDA. So like for patients, like their individual doctor does not have any input as far as what medications get a black box warning or not. And what's hard is, so same thing, of course they're trying to be on the conservative side as far as being safe for people, but a lot of times it is kind of teasing out what are the minutia of what caused a medication to get a black box warning, because a lot of times it may not even have to do with the specific medication itself, because a lot of medications are in a family of medications. So for instance, like for high blood pressure, there's beta blockers, which are like propanolol and all the alols, atenolol,
Mhm.
it's metoprolol. There's a class called ACE inhibitors. Like there's a whole bunch of different classes of medication. Same thing with biologics. Whether you're saying for psoriasis, you can say, are you IL-23,
Mhm.
IL-17, et cetera, et cetera, et cetera. But let's say it was for, even if it was for a different disease that they were using this medication for, and oh, by the way, this other disease, the patients were either potentially a lot older or a lot sicker or had this other comorbidity or et cetera, et cetera. But oh no, if they had that problem though, now we're going to make the black box warning over that whole category when it has
Mm.
nothing to do with, but my patient has atopic dermatitis or has, whatever your condition is, that they don't even have the disease that they put, like cause them to put the black box warning to begin with. So then that's where, as a physician, you have to tease through all the information and
Mhm.
then know what you need to ask or go through with your patients, so that they understand the black box warning and then make sure
Right.
they're okay with it and go from there. But you're right, the more complex and
Mhm.
the more hoops and things you have to explain, the less likely people are going to prescribe it, just because it starts getting a little too difficult for some people.
Yeah. Do you think when a drug has multiple indications, it increases that risk for these adverse events or anything else to
That's
happen?
a good question. I mean, it's certainly possible. Again, what's hard is depending on the conditions that it's used to treat. Certain conditions go with, they often will have what are called comorbidities, or they'll have other conditions that they're associated with. So, if that happens to be one of the other things that a medicine, let's say that I use or a given physician uses, then yeah, you have to be, I guess, in your mind, like if there's an issue that's going on with that comorbidity, but that comorbidity is associated with the disease, like it kind
Mhm.
of is a trickle down, if that makes sense.
Yeah, yeah, absolutely. I think it's so interesting. I don't know, maybe it's just the nerd in me, like with the clinical trials. I love hearing it, but I think it's also good for people to understand clinical trials and,
Oh, I
the
agree.
reason why they exist, and also being aware that, because you do see these commercials on TV, and sometimes it can be scary when you're like, "Oh my gosh, these are all the side effects." It's
Yeah,
like,
no,
"Oh,
I agree.
I don't want to take that medicine."
I agree also, because the thing that's hard is, the way they phrase it, it sounds like, yes, like there was a very high likelihood you could get any or all of these. Whereas a lot of these side effects maybe happened in 1% or less of the, patients that were in the trial, or, like then you have to really dig through the data on that. But yeah, that's where when I'm talking to my patients about it, I'll tell them the whole thing I just told you before about the Pepto Bismol thing, that I'm like, no, no, no. So that's how we get if different side effects are in there. The other thing too, and I think you bring up a great point, is just because a side effect is listed, that doesn't mean you're going to get it. They're just
Hmm.
putting it out there. Like let's say headaches is an issue, but if you already have a lot of issues with headaches already, then that may be something to talk to your clinician about, to say like, hey, I was interested in X medication, but I heard that it caused headaches, and I already have a lot of issues with headaches. Is this something that I can still take, or and kind of
Hmm.
tease that out?
Yeah, absolutely. That makes so much sense. So when you are starting a trial and there's certain questions and criteria, is that something that you have that's standard across the board for anybody that's enrolling into a clinical trial, or is that already just set by the manufacturer?
So a little of both. So the manufacturer will actually have a consent form that every patient, before you even ask them or tell them anything specific about the trial, that they sign. And I kid you not, this consent it's not like a one piece of paper. Like it's usually like this fat. So it goes through everything with the trial. But you're right, a lot of these medications, especially because a lot of the trials that I do are more phase 3 trials, so we already have some data on the medication, either from the previous trials or if it's already released on the market for another indication. But let's say the trial I'm doing is for a new indication. We already have
Mhm.
a fair amount of data, on that given medication. So for me, when I'm talking to patients about it, I'll also discuss it to them the same way I would discuss to any other patient that I was bringing it up to. What are, again, potential side effects, things we have to look for, monitoring. Do you have a family history of X, Y, or Z? I'll bring that up regardless. So
Mhm.
that's what I'm saying. It's a little bit of both.
Yeah. And then what are some of the most common concerns that you hear from patients when they're starting a clinical trial?
Sure. So big ones are like, well, I don't want to be a guinea pig. I don't want to be like experimented on. And I agree. No one wants to be a guinea pig, and no one should be a guinea pig. The good news is, again, especially as the trials get further along, it's not like someone's like rummaging in their storage drawer and is like, this is what I'm going to try today. Like, oh no, that didn't work. I'm going to try this. Like, no, no, no. Like, there's actually been a lot of data, and you had to do something before you could even give it to someone to take or to take.
Yeah.
You're not just rummaging and finding something. So there's definitely a method to the madness in that one. The other big thing I always emphasize to patients is, like I was saying before, you are in control of this trial. Like, I'm happy to help you all along the way and answer any questions you have along the way, but I don't want anyone ever to feel like they are in research jail. If something is going on, whether uh, whatever it is, they decide they don't like me, like, okay, no problem. Let's get you out of the trial, and then you can do what you like. Or if it is an issue with the medication, either way, whatever it is, they are in control of when they get in or out of the trial, and we will never judge them one way or the other. And we're like, no problem, assuming it's not that you didn't like us. If you get out of the trial, then we'll just see you on our regular clinic side as opposed to in our research side. But we
Hmm.
can treat you, and I won't treat you any differently just because you decided to leave a trial early. Like, I want what's best for the patient. So if the patient feels like what's best for them is to get out of the trial, then we need to get you out of the trial. But if it's
Hmm.
looking like being in a trial is going to be an awesome potential benefit for you to get to try a medication that you might not otherwise get to try, let's do it. Let's see what
Yeah.
we can do to get your disease doing better.
Yeah, absolutely. I think there should just be more education around clinical trials and the reason why they're available, and just some of those, kind of hitting some of those concerns that people might have, and just general education I think would be so helpful around
I,
it.
I think so too. The other thing too that a lot of trials will do to try to help patients, not only with enrolling, but getting them the treatment they need. Because what's always hard with a lot of these trials is to get FDA approved. Usually, and this also is dependent a little bit on the condition you're treating. Because certain conditions, it's not ethical to not give someone treatment for a given amount of time. Like, don't get me wrong, eczema, psoriasis, even hidradenitis, like, you're itchy, you're potentially painful, you're not, no one wants to experience any of that. But if it's for 12 weeks, 16 weeks, and then after that, like, okay, there'll be an extent, even if it's 24 weeks, whatever, we know there's going to be an extension where then if you were potentially randomized to a placebo, you'll get active medication at that point. If someone has cancer, you're not going to put them in you can't just not treat cancer.
Mm-hmm.
So the cancer trials are sometimes a little bit different than some of the medical trials, or again, depending on what the condition is. But no, I think just for patients to really understand how it works and what their role is in the trial, I think would be great, because no one is looking to try and experiment on people. We're trying to get people the best treatment they can as soon as they can.
Right. Yeah, absolutely. So you work with a lot of students and residents in your practice.
I do.
Do you help to train them on clinical trials as well as dermatology, general dermatology?
Yeah, I mean, I answer their questions as much as they want to about it. One thing that can be a little tricky, I mean, we do clinical trials right now also in alopecia areata and psoriasis. Hidradenitis suppurativa is the main thing I'm doing my trials on, but by nature of just where a lot of these people that their condition is at, a lot of times they want as few people as possible in the room. So a lot of my clinical trial patients for HS often don't want a medical student or a resident in the room, which I don't blame them. I know it's not, I mean, it's not fun even on a general skin exam to have to show your genitalia or something to someone. But then if you're dealing with a condition that's there as well, I get it, and obviously that we never push on anyone, either the patient. It is always up to them if they're comfortable having a rotator in the room or not. But long story long, yes, I will answer and give information to students and residents about clinical trials, because same thing. I want them to be able to explain it to their patients in the future. And again, honestly, even if they're going to do clinical trials or not, if their patients talk to them about potentially entering a trial, well, then now they can educate their patients a little more on, okay, well, this is, roughly the process you'll have to do. And, so they can, and again, dispel any misinformation and give the patients they need to get the treatment they need.
Yeah, absolutely. So what is your hope for the next generation of doctors coming along?
Ooh, that's a great question. So, I guess a few hopes. The first one is, I know right now, and especially with the times being what they are, it's easy to unfortunately sometimes feel a little cynical or disenfranchised or negative. But we really get to do something for people that no other field or any another line of work gets to do for people. We are literally in a position that we can save people's lives on a daily basis. And don't get me wrong, I know it's rough. I went through those 3 years of working literal 80-hour weeks at times, and sleeping in the hospital. And I'm not saying the road is always fun, but I can't imagine doing anything else. So the big one is, don't give up hope. Don't be cynical. And, just remember how big an impact you can make on our patients' lives. And it really makes a big impact on us too, and there's nowhere else you're going to find that.
Yeah, absolutely. Okay, other last question about clinical trials.
Okay.
Is there anything that you're really excited about that is in the pipeline that we can not, I mean, you don't have to tell us what it is, but anything that you can share that is coming that you're excited about?
Yeah, so again, not to sound like a broken record, but for HS, there is so much in the pipeline right now. Like, it's ridiculous. Right now, I'm president of our Nevada Derm Society. And last year at our annual meeting, I gave a talk on all the things that were in the pipeline to come through. And I remember at the time when I was going through all the papers to get the talk together, like, it was like, wow, this is awesome. There are so many things in the making. And now a year later, like a lot of those medications that like they were still getting ready to start the trials, well, now they've already started them and they're starting to recruit for them. Or medications that were in trial, like now they're getting that much further along. So, I mean, it's exciting just to see how much is there and how much potentially is still going to be there for the future. So for all our patients with HS out there, definitely don't give up hope, because there are so many things coming in the pipeline and there are so many of us that care. Like, you will get to where you want to be. Unfortunately, it has been a long road to get there, but there are so many things there and so many things in development. It's very exciting.
That is exciting.
Yeah.
I love to hear that. Okay, I have, because you're in Vegas, I have some playing cards that I had made They're
Ooh,
called That's Derm Good playing cards.
okay.
So I have a few categories, and I was going to see if you are interested in playing a little game. It's
Sure. Yeah.
so we've got derm disasters,
Okay.
behind the glow, access and advocacy, and skin deep.
Ooh.
So maybe we can choose a couple and then see what question we get.
All right. Let's start with derm disasters.
Okay. All right. Let's see. Let me shuffle these up here. See what we get. All right. First question. Okay. Have you ever tried a trend you immediately regretted?
Oh, um, not necessarily a trend, but I remember like years ago, and I have to talk to my patients about this so much now. Topical retinoids do so many great things for the skin, but for a lot of people, they can be drying, and especially here in Vegas with how dry it is, you have to be careful that, especially if someone has never used a topical retinoid before. Two things: a little goes a long way. Like pea size is all you need for your face. And again, if someone has never done it before, I'll tell them start slow. Like the first couple of weeks, do it 2 nights a week, moisturizer and sunscreen during the day. Then after the next couple of weeks, every other night. And then next, if you're still doing great, then you can go to every night. But, all of us want everything now.
Yes.
And I can remember at one point, I was in college and I started using a topical retinoid, but oh no, I'm going full court press. And of course, I started doing it every night from the get-go and turned myself into a tomato. And then I realized like, oh, I need to do this a little more slowly and wear my sunscreen. And then it got
Yeah, I've been there.
yeah. So, but hey, time happens, and now I'm using a super strong retinoid every night, and my skin's all good. So everyone's body is different, and also where we live is all different. So depending on how humid, how dry it is, you got to take all that stuff into account.
Yeah, for sure. All right. Let's see. How about let's do behind the glow.
Okay.
All right, let's shuffle up these. Okay. What's one skin related hill that you would die on?
Oh, skin related hill I would die on is sunscreen every day. I don't know any dermatologist worth their, that doesn't wear their sunscreen. So yeah, that broad brimmed hat, sunglasses, I have no problem wearing those every day. And sometimes, sadly, to the chagrin of my family, I'm like, "Where's your sunscreen?" But yeah, sunscreen
Yep.
is a very important part of our household. So
Yes, absolutely. All right, we've got skin deep and access and advocacy.
all right, let's do access and advocacy.
Okay. Let's see here. Okay. All right. What is the biggest hurdle you face getting meds approved?
Oh, the biggest hurdle, unfortunately, is that I feel like when you're submitting something, the first answer, a lot of times, it's almost seemed like it's going to be no. And it's like,
Mm-hmm.
but I already put that this is what they've tried and failed. Or sadly, I had a 5-year-old, I was trying to get an approval for a biologic, and the medications they wanted me to have the child use are not approved for that age group. So I'm like, okay, like this doesn't even make sense. You want me to use medication that then, what would happen
Yeah.
if I tried to ask for that? You would say it's not approved for that age, so
Right.
it doesn't even make any sense. So it's more, I feel like that your answer is always going to be no, 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 fine.
Mm-hmm.
Okay. So unfortunately, it feels like they are hoping that someone will give up during those first 20 no's, and then they won't have to say the fine at the end. I think that's the
Yeah.
hard part.
Yeah. I agree 100%. It's definitely a lot of how you word things too. It's like now you almost have to put the pressure on the insurance company and say, "Hey, I'm the doctor. I'm the one who is writing this. Like you guys are not prescribers. You need to stop trying to dictate what the patient can and can't be on."
Yeah,
It's
no, it's
frustrating.
very hard, and to me, it's not even just medications, but it's procedures and blood work
Mm-hmm.
and like ridiculous. Like I never forget, this was several years ago, but I had a patient that she was like in her 40s that we were treating for acne, and at the time she was on the birth control pill, and we had already discussed this with her gynecologist. Even though she's over 35, it was fine, et cetera, et cetera, et cetera. Well, then I saw her one time for follow up, and she had stopped it because her sister had had a blood clot. And birth control pills for certain patients, especially if they're over 35, can increase your risk of blood clots. And so I was like, oh, well, some of those conditions that can cause blood clots can run in families. So then now my internal medicine brain, we were talking about, so that turned on, and I'm like, well, do you know what caused her blood clot? And at first the patient was like, no. And I was like, well, we need to order a workup on you, because obviously if you get a blood clot, that can be life-threatening. So first I try to order the whole panel, and of course the insurance goes, which I'm sure they are also probably like, why is a dermatologist ordering a hypercoagulable workup? But then the patient actually gets back to me. She's like, no, I found specifically what caused her blood clot. And actually both of them were genetic conditions. And this was a blood sister, like it wasn't a stepsister. So she was like, no, it was these two things. I was like, well, we need to order them, because you could very easily have this and may need to be on aspirin or something, proactively, or even a blood thinner, to prevent you having a blood clot in the future. So I submit for them, and like I have her sister's thing, in the chart, and the insurance denies one of them. And without insurance, and this was 12 years ago, was going to cost a good $500-$600, so the patient's like, I can't afford $500-$600. And, then it's one where I'm calling, to talk to the person. And I'm usually a very like happy, cheery type of person. And I was literally almost kind of yelling on the phone, like to the point that afterwards my MA was like, what was going on? Like, I'm not like, are you okay? Like, I'm not used to hearing you get angry on the phone. And unfortunately, I know it's not the representative who I'm calling. That person did not make the rule. But, I was like, I want your name. I want your, because I'm going to put this down, because heaven forbid, if this patient has a blood clot, I want it documented that we discussed this, that so it's in there, like it's going to be in their chart and part of their record that, their insurance knew all, like I'm explaining all these things, that this is a genetic test, this is a blood relative, and why are you denying this? And this is a sister, like they share parents, like, why are you denying this?
Right. That's crazy.
Yeah.
And what is crazy is like insurance companies bring that side out on a lot of us that are working in access. It's frustrating.
Yes.
We get so angry with them, and it's not the person on the phone, because they're the ones that just have to read the guidelines.
I agree. Like,
they're the messenger. Yeah. But at the same time, there's still these policies, and, insurance companies just don't understand that. Or it's the PBMs. I think a lot of is just,
well, definitely from a medication standpoint. Yeah. I mean, this one was a lab, but still, I mean, it's like, you realize if this patient has this and doesn't know it, she could form a blood clot and die. Like, do you really want that on you? Like, that's horrible. Why are we saying we're waiting for a patient to throw a blood clot? Like, that is not medicine.
No, not at all. I feel the pain.
Yes.
I understand. Okay. Last one I have is Skin Deep.
Okay.
So let's see. Shuffle these up.
All right.
Okay. So what's your holy grail product and why? And you already said sunscreen before, so let's go with a different one. I knew you were going to say that.
Oh, Melly. Well, okay. Am I just saying for like just overall skin health, or like what is like,
just your holy grail product and why? Ooh. So yeah.
Okay. So this is a hard one, but I'm going to say, just because I feel like it pertains to the broadest number of people, is moisturization. Because again, especially here in Vegas, like it is so dry, a good, just real mild moisturizing cream. Sorry for everyone that loves their Bath and Body and Victoria's Secret products, but unfortunately, especially if you have things like contact dermatitis or atopic dermatitis, those are not going to be your best friends. Like if you go in my bathroom right now, 99% of the things you find, unless it was something like I happened to get as a gift or something, like they are all things you could buy at your local pharmacy, grocery store, like just plain Jane good moisturizing creams. And you want a cream, not a lotion, because lotions tend to be water-based, so they can evaporate more quickly. Creams are a little bit thicker, but definitely moisturize better.
Okay. Very good.
Yeah.
Love it. Well, thank you so much. That was fun.
That was a lot of fun. Yeah, this was great.
It was such a pleasure talking with you, and I really appreciate you joining me. And hopefully I'll see you in Vegas.
Definitely.
I'll be out there multiple times. So
yes, please look me up.
For sure.
Fantastic. Have a great rest of your day.
Thanks. You too.
Okay. Bye-bye.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.